Okay, I think we can start now, Ravali.
Good evening, everyone. This is Ravali, pursuing General Medicine second year from Ramesh Hospital, Guntur. Today, I want to present about the topic organophosphorus poisoning. Actually, these compounds are very important because these are the important cause of poisoning in humans in the developing countries. These have been used as pesticides and petroleum additives. They are also synthesized as chemical warfare nerve gases like sarin, tabun, and soman. And these gases are absorbed through the skin, that is through the direct contact, and they can be absorbed through splashes, like they can affect the conjunctiva and oral mucosa, and also they can affect the respiratory tract system by inhalation, and they can also get injected. And now from the nerve gases, these compounds are prepared now like diethyl compounds and dimethyl compounds. Diethyl compounds are chlorpyrifos, diazinon, parathion, and phorate. Dimethyl compounds are dimethoate, dichlorvos, malathion, and phenathion. And other group of compounds are there, that is carbamates, which are closely related to OP compounds. And these compounds have a carbamate ester group as a functional group. And these compounds are aldicarb, carbofuran, carbaryl, ethenocarb, phenobucarb, oxaryl, and methonyl. And the mechanism of action. OP compounds and carbamate compounds are usually acetylcholinesterase inhibitors. And the bond between the OP and acetylcholinesterase changes with time and becomes irreversible. So when it becomes irreversible is when one of the alkyl radicals gets separated from the OP compound. And the process is called as aging. The time course of aging depends on the molecular structure of the OP compounds. And the aging is usually shorter for dimethyl compounds than for diethyl compounds. And the carbamate compounds are transient cholinesterase inhibitors, which spontaneously hydrolyze from the cholinesterase enzymatic site within 48 hours. So there is a shorter duration of toxicity for carbamate compounds. There is the inhibition of both RBC and plasma cholinesterase activity levels, so which leads to the accumulation of acetylcholine at the synapses, causing overstimulation and disruption of acetylcholine receptors at the muscarinic, nicotinic, and central nervous system sites, leading to toxic effects of both CNS and PNS. And these OP compounds are rapidly distributed in all body tissues with the highest concentrations, which are seen in liver and kidneys. Clinical features. There are mainly three stages in OP poisoning. First stage is cholinergic crisis. Second one is intermediate syndrome. And the last one is delayed neuropathy. Cholinergic crisis. This crisis usually develops within first 30 minutes to 3 hours of exposure to the poison, and it depends upon the type, quantity, and route of exposure. The symptoms usually occur due to the excessive stimulation of muscarinic, nicotinic, and central receptors. Most of the patients have manifestations of overstimulation of the parasympathetic nervous system. And the symptoms, how we remember, are the sludge and dumbbells. Sludge means sweating, salivation, lacrimation, urination, diarrhea, gastrointestinal cramps, and pain. E for emesis. And you can also remember it as dumbbells. That is diarrhea, urination, meiosis, bronchoria, bradycardia, emesis, lacrimation, lethargy, and salivation. And the nicotinic effects are tachycardia, hypertension, muscle fasciculations, muscle cramps, muscle weakness, and respiratory paralysis. And it can also involve the CNS, which, when it is affected, it may lead to agitation, confusion, psychosis, delirium, convulsions, and coma. If there is severe poisoning, they can have convulsions and they can go to coma. And OP compounds usually affect the parasympathetic system mostly, but they can also affect the sympathetic system, and they can also involve the CNS. So when the maximum, if they affect the maximum at parasympathetic sites, they cause all the parasympathetic manifestations, and they usually occur below 24 hours, less than 24 hours. And the mechanism of action is they act on nicotinic, muscarinic receptors and also at central receptors. And how they manifest are, if muscarinic receptors are affected, they manifest as bradycardia, bronchoria, bronchospasm, diarrhea, hypotension, lacrimation, meiosis, salivation, urination, and vomiting. If the nicotinic receptors are activated, they can go to tachy, mydriasis, sweating. That is sympathetic. If nicotinic receptors are activated, if the sympathetic pathway is activated, then they go to mydriasis. So in OP poisoning, they can have either meiosis or mydriasis based upon the system which is activating, whether it is parasympathetic system or sympathetic system, the symptoms occur. And if they act on central nervous system, they can have coma, confusion, and respiratory failure as discussed. And the symptoms are classified based on Reisbach's criteria classification, and it is divided into 3 types, like mild poisoning, moderate poisoning, and severe poisoning. When the symptoms are nausea, vomitings, diarrhea, and sweating, it is called as mild poisoning. And if lacrimation, salivation, and fasciculations occur, they're called as moderate poisoning. If ARDS, seizures, coma, areflexia, and if incontinence, either fecal incontinence or urinary incontinence, and if there are any apneic spells, they're called as severe poisoning. Initial cholinergic crisis usually lasts for 24 hours to 72 hours. But some OP poisonings like diazinon and phentheon and methylparathion, they have more lipid solubility, so they cause delayed and persistent cholinergic symptoms due to the late release of toxins from the fat storage. And the respiratory paralysis which occur in this stage is called as type 1 paralysis or acute paralysis. And the next type is intermediate syndrome. This usually occurs in 10 to 40% of patients after 24 hours to 96 hours of exposure due to recirculation of a lipid-soluble OP compound into the blood. And they are characterized by mostly neurological findings are present in intermediate syndrome, and those are pharyngeal weakness, neck flexion weakness, decreased deep tendon reflexes, cranial abnormalities, proximal muscle weakness, and respiratory insufficiency. And the paralysis which is caused in this intermediate syndrome is known as type 2 paralysis and usually lasts for 4 to 18 days. And why this occurs is due to the variable susceptibles of cholinergic receptors and prolonged action of acetylcholine on nicotinic receptors and inadequate treatment with antidote, that is prelidoxime or any oxidative stress-related myopathies. It is almost never seen in carbamate poisoning, and the risk of mortality is due to the respiratory depression because of muscle paralysis. And the last syndrome is delayed neuropathy. Some OPs like triorthocrysyl phosphate and tricrysyl phosphate produce type 3 paralysis, also called as OP-induced delayed polyneuropathy. It occurs 2 to 3 weeks after exposure and is characterized by distal muscle weakness leading to wrist and foot drop. The recovery is slow and occurs over months. It is due to the inhibition of neuropathy target esterase. And the diagnosis, how to diagnose OP compounds. They're characterized by pungent garlic-like odor, which can be identified from patient's breath or any aspirated stomach content. And along with this, it is important to identify whether the patient took any other compounds like kerosene or pyrethroid poisons. And also we can send plasma, that is pseudo or true cholinesterase levels, which are usually depressed by at least 20 to 30% in patients with clinically significant OP poisoning. Low initial plasma or RBC cholinesterase and high glucose levels are useful markers in predicting OP-induced intermediate syndrome. But in the presence of clinical features of OP poisoning, one should not wait for laboratory tests and should start treatment immediately. Also, in some OP poisoning patients, there is delayed depression of cholinesterase levels. So normal initial levels don't exclude OP poisoning. In confirmed cases of OP poisoning, other blood investigations such as CBC, GRBS, LFTs, RFTs, and serum amylase are often required. Elevated GRBS, serum amylase, and lipase levels are associated with poor prognosis. And we also have to do chest X-ray to know the complications like pulmonary edema, ARDS, or aspiration pneumonia. And ECG also can be done to know whether any QT interval prolongations or any heart blocks or any T-wave changes. And there are similarities with organophosphorus poisoning. Some compounds have the same similarities like mushroom poisoning and botulism, pyrethroid pesticides, organochlorous poisonings, opium poisonings, and cholinergic drug toxicity. The similarities are with mushroom poisoning. OP poisonings also have cholinergic toxidrome due to muscarinic receptor stimulation. But in mushroom poisoning, there is delayed manifestations and organ failures. In botulism, the similarities are diarrhea, muscle weakness, and respiratory weakness. But they have bulbar and facial weakness and descending paralysis. In pyrethroid pesticides, they have pesticide smell. Both have pesticide smell, excessive salivation, tremors, fasciculation. But in pyrethroid, there is absence of other cholinergic symptoms, and there is normal red blood cell cholinesterase levels. In organochlorine poisoning, similar pesticide smell is seen, but pulmonary edema and seizures are also seen in organochlorine poisoning. Seizures are very rare presentations in OP poisonings. Opium poisoning, both have pinpoint pupils and respiratory failure. But in opium poisoning, there is early loss of consciousness and prompt response to naloxone. In cholinergic drug toxicity, there is pinpoint pupils and respiratory failure, but history of drug ingestion can be seen. And how we manage the patients. Main goals of therapy are, first we have to do initial resuscitation, removal of the unabsorbed poison, antidote therapy for absorbed poison, management of complications, and prevention of poisoning in the future. Emergency resuscitation. First, we have to check the saturation levels and we have to check whether the oxygen levels are maintained. If oxygen saturations are dropped, we have to supplement the patient with oxygen. And if there are pooling of secretions, turn the patient into left lateral position to prevent aspiration. And we have to suction at regular intervals. If there is hyperventilation, patient is not tolerating on oxygen support, go for mechanical ventilation. And if there is drop in the blood pressures, go for inotrope therapy for hypertension. And in addition to any other, along with fluid resuscitation with crystalloids, if there is a drop in blood pressure, you have to go for inotrope therapy. And urinary catheterization, since they develop urinary retention, once antidote is given, secure IV line for antidotes. Decontamination and gastric lavage. Thorough wash of skin and hair with soap and water after the first dose of atropine. IVO should be given to patients who have conjunctival exposure. Once the patient is stabilized, Ryle's tube should be inserted for gastric lavage in patients who present early after ingestion, that is less than 2 hours. And for decontamination, we give activated charcoal, which is administered at a dose of 1 gram per kg. Maximum you have to give for 50 grams after stomach wash for patients presenting within 2 hours. Induced emesis should be avoided. Antidote therapy. Atropine prevents cholinergic activation by competing with acetylcholine at muscarinic receptors, but there is no effect on the nicotinic symptoms. And it should be administered immediately on diagnosis, beginning at a dose of 1.8 to 3 mg IV bolus. And what are the 5 markers which indicate the requirement of atropine are meiosis, excessive sweating, poor air entry due to bronchoria or bronchospasm, bradycardia, hypotension. So for 5 minutes, we look for these symptoms. If the symptoms are persistent even after 5 minutes, we double the dose of atropine till the atropinization occurs. Target endpoints for atropine therapy are The chest should be clear on auscultation with no wheeze. Heart rate must be more than 80 beats per minute. Pupils should be no longer pinpoint. Dry axillae, systolic blood pressure must be more than 90. Once the targets are achieved, the patient needs to be maintained by continuous infusion of atropine, which is usually 10 to 20% of the initial total dose every hour, preferably by infusion pump. And the patient needs to be monitored frequently by maintaining an atropine chart. The atropine chart contains pulse, blood pressure, secretions, temperature, and pupils. Initially, every hour, atropine chart must be maintained, and then at less frequent intervals till 48 hours. In most cases, atropine can be tapered gradually from day 2 to day 5 of poisoning. Glycopyrrolate. It is another drug which controls the secretion in OP poisoning with fewer neurological side effects like delirium and agitation. Muscarinic signs like coma and drowsiness will not respond to glycopyrrolate since it does not cross the blood-brain barrier. It is given as a repeated bolus of 0.4 mg. Pralidoxime. Pralidoxime, along with other oximes like obidoxime, are cholinesterase reactivating agents. They are capable of counteracting both muscarinic and nicotinic effects of OP poisons. Oximes are generally not given to patients with carbamide poisonings. WHO recommend that to administer pralidoxime in a dose of 30 mg per kg IV slowly over 30 minutes, followed by infusion of 8 mg per kg per hour, maximum dose is 500 mg per hour in adults. Rapid infusion must not be done because they cause tachycardia, laryngospasm, and transient neuromuscular dysfunction. Oxime therapy is continued till atropine is required, as the oximes can transiently induce cholinesterase inhibition and worsen the symptoms. Dimethyl compounds undergo rapid aging, making early initiation of oxime therapy critical, and diethyl compounds exhibit delayed toxicity, so they can require prolonged treatment with pralidoxime. Dizziness, blurred vision, headache, diplopia are the few common side effects of oxime therapy. Magnesium therapy. It's also used along with atropine and it is found beneficial. Like the mechanism here is OP antagonizes the OP by blocking the calcium channels and thus reducing the acetylcholine release from the presynaptic terminals. Early administration of magnesium sulfate has been shown to reduce the duration of hospital stay and also improve the outcome. However, it must be used cautiously as IV magnesium therapy can cause respiratory depression and should not be used in non-intensive care setting for OP poisoning patients. Supportive management. Intravenous furosemide or diuretics are required in patients who develop pulmonary edema. Broad spectrum antibiotics should be used in case of any aspiration of stomach contents or any multiple interventions predisposing the risk of infection. Drugs like aminophylline, theophylline, morphine, succinylcholine, and aminoglycoside group of antibiotics should be avoided because they increase the risk of toxicity of exposure. And psychiatric counseling is required in case of suicidal ingestion of OP compounds or in cases with neuropsychiatric side effects due to the poisoning. How we manage the complications. Atropine toxicity manifests with hyperthermia, delirium, tachycardia, dilated pupils, absent bowel sounds, urinary retention, and sometimes life-threatening arrhythmias and rhabdomyolysis. Atropine should be stopped and restarted at a lower dose when these manifestations reverse. The possibility of other causes like alcohol intoxication, hypoglycemia, concomitant poisoning, and head injury should be considered. They are treated with midazolam or diazepam with close monitoring for respiratory depression. Management of intermediate syndrome requires a close watch for respiratory paralysis and if required, mechanical ventilation we have to do. Prognosis. Most of the patients with OP poisoning can be salvaged without any long-term sequelae. Mortality is estimated to be 10 to 20% despite treatment. Deaths are usually due to respiratory failure or cardiac toxicity. Certain compounds such as fluoride, phenthionine, and dimethoate are notorious. Patients who present after 2 hours of poisoning or have simultaneous alcohol, pyrethroid, and kerosene poisoning or a GCS of less than 13 on admission are at higher risk of death. Early initiation of decontamination and antidote therapy with close monitoring for complications are the most important in preventing deaths due to OP poisoning. Thank you.
Hello. Yeah, it is a very good PPT and a good presentation, Ravali. And okay, I have a few questions for you. You have said regarding pseudocholine right? Could you tell what is its role of pseudocholine? Does it have any role in determining the prognosis of OP poisoning? Hello.
Hello.
Yeah. Am I audible?
Yeah.
Yeah. Is there any role of pseudocholine in determining the prognosis of OP poisoning?
I actually don't know.
Actually, the thing is, since all this poisoning are medical legal cases, there is a very much liability for us. So we have to be very proper in our documentation. Actually, pseudocholine has a role in determining the prognosis of the patient. So since you have mentioned in your PPT that you will not delay your treatment based on these reports, you will initiate the treatment based on the clinical history and also the examination findings. But you will send a serum pseudocholine initially, and then you will repeat it after your atroponization and antidote, and you will see a fall in the serum pseudocholine tells us that okay, the toxicity levels are decreasing and that the level of prognosis will be better. So that will give you a medical legal evidence that the poisoning that the patient has taken is properly an OP poisoning, because all the patients who consume OP will not come with a label to us. So it is one of an evidence for your diagnosis, at the same time for telling the prognosis to the patient.
Okay.
And the next thing is, you have mentioned that in intermediate syndrome, that lack of proper doses for intermediate syndrome. Yeah, it is one thing. And is there any role that lack of atroponization, does it predispose a patient for intermediate syndrome?
It may lead to intermediate syndrome.
Yes. Not only paradoxin, but lack of atroponization also is responsible for intermediate syndrome. And see, the other thing is like, okay, all the doctors in the ER who will see an OP poisoning case, what is the first thing that you want to tell them? Like one precaution for a doctor, whoever visits a OP poisoning case.
They have to wear all the gloves and they have to take care of them, because it can spread through inhalation or any contact also.
Yes. So, see, you should be on your tips to treat the case, but your safety is first thing. So, always take the precautions of wearing gloves before you touch the patient. So, she have mentioned in the PPT that you have to thoroughly wash the hair and the skin of the patient, change his clothes, because thermal absorption is also one of the route for poisoning. And the other thing, you have mentioned that you will give an activated charcoal to the patient. Yes, it is one of the most commonly used one to inhibit the absorption. Can you name any other compound that can be used to hinder the absorption apart from activated charcoal?
No.
See, cholesterol, which is a bile acid sequestrant, can also be used to hinder absorption.
Okay.
Okay, so you will have a toxicology book, which is a Goldfriend's toxicology, but to go through in that, they'll mention you cholesterol. And see, as we know that the substance that has been absorbed, you'll try to prevent, that has not yet been absorbed, you'll try to prevent it by giving an activated charcoal. Okay, like you have given an activated charcoal, the patient has admitted into your ICU, he hasn't passed. So what is the other thing that you are more cautious? Apart from all this CNS involvement, respiratory depression, apart from this, the other thing that you should monitor is?
His vitals.
Apart from that?
He may go into aspiration because of pooling of secretions, all those. So we have to take care of that.
The other thing is make sure that your patient should pass stools immediately. You don't let him delay it more than 6 hours. So what are the other things that you will, apart from Duflac, you have given Duflac to the patient, he hasn't passed stools. What else will you do? You have given an enema, he hasn't passed stools. The thing is, you will keep a prokinetic. See, amoxicillin is one of the better prokinetic. We all prefer going for domperidone or metoclopramide as prokinetics. So in OP poisoning, if a patient hasn't passed stools despite your Duflac of 15 ml TID, you can go for an amoxicillin, which is a good prokinetic. And we have to let the patient pass out the stools, because it is one way that will cause a delayed absorption of the substance still more.
Okay.
So that is one thing. The other thing is, the only you have said that what are the markers for heteropenization, right? So out of the 5 markers that you have listed, what is the one most significant marker based on which clinically you're going to change your atropine dose?
Secretions, which we hear in chest.
Yeah.
Auscultation. On auscultation, what we hear.
Okay. And the other one is, okay, you have got a case, you have started him on paradoxim as a start dose of 2 grams followed by an infusion. Till when are you going to continue the infusion? You have mentioned it in your PPT, but as per when are you going to continue, till when are you going to give your paradoxim dose?
Actually, there is no role once the compound is irreversible. Once OP is attached to acetylcholine estrase, it becomes reversible only for 1 to 2 days. Once it becomes irreversible, there is no role of PAM. So, but we actually don't know when it gets irreversible. So till then we can use, that is maximum 1 to 2 days. But
No.
some persons follow for 5 days and some persons follow for 1 day only.
Okay. So you have said that you will start as early as possible. That is correct. So
Yes.
certain books tell that you have to give palm till the patient is not needing any atropine requirement for 24 to 48 hours. That is one school of thought. And certain people okay, it's not necessary that all the OP poison need to present with all the manifestations that we have discussed till now. There are certain people who will not even have minimal symptoms, so we just give him atropine dose of 2 mg TID or 2 mg QID doses. We even don't give him boluses repeated after every 3 minutes, because the clinical scenarios also vary.
Yes.
And the other thing that you have mentioned is the DDs. They are very well mentioned in the PPT. So you have got a case with a 31-year-old female who was brought to the ER in an unconscious state, and the attendant is telling that there was frothing from her mouth. Apart from that, there was no other history told to us. So what is the next step that you want to do with the case? She was brought to you with a GCS of 4/15, and her pupils are pinpoint and not reacting to light, and there are no other signs of excessive salivation and all that.
It can be pontine hemorrhage.
One thing, yeah,
it can
but
be
31-year-old with a pontine hemorrhage with no comorbidities, that is other thing not fitting much into the
any trauma.
There is no history of trauma which the attendants have told. They have gone to their house, they have seen the patient lying on the floor just with the frothing from the mouth.
Opium poisoning.
Yeah, one thing is you have to be very suspicious of this. See, we have seen a case this way: 31-year female with no comorbidities, who she was brought to the ER with a GCS of 4/15. Her pupils were not completely pinpoint; they were mid-dilated and reacting.
Okay.
And the history was like her daughter who bought her was telling like it's a seizure. We didn't know the cause for seizure. Her CT brain was normal. And the thing was, she has to, we on persistent asking, there was a history of suicidal tendencies, and then she has revealed that it was an OP poisoning presenting as seizure, only as a seizure, without any other symptoms of cholinergic crisis.
Okay.
So always any patient who is presenting to you with any atypical symptoms, always keep in your mind to ask any query regarding a suicidal tendency, because many patients, whenever attendants, when you provoke them regarding the history, many will be hesitant to tell it. But when your diagnosis is not fitting into the clinical examination of the patient, always go through it. The rest, do anyone have any queries regarding it? And so I think we can conclude the session, and it was a very good presentation. You have covered the topics, everything in the detail, and it is very thankful. And we are very thankful for you for such a good, valuable information. Thank you.
Thank you, Samina.